Now, Dr. Ralph Sacco, professor and Oldenburg Family Chair of the Department of Neurology at the University of Miami, and I discuss vascular cognitive mechanisms and diagnosis. Ralph, welcome to ACCEL, and it's very nice to have an opportunity to talk to you in a more technical basis because we're always involved in the organizational things. Let's talk about vascular impairment, vascular cognitive impairment. I think it's a very important topic because of the shift in the age of the patients we're seeing now and the propensity for this kind of thing to occur. And I will say, in my own practice in general cardiology, I see families come in oftentimes with the father or the mother showing signs of neurodegeneration, and we always think, well, it's got something to do with the cardiovascular system. So why don't you tell us about that a little bit? I think it's a very important topic these days.
Well, thanks, Fred, for the opportunity. Vascular cognitive impairment is a huge problem, and I think will be growing in the country. As you stated, the population is aging, and one of the biggest concerns of people who get older is age-related memory loss, losing cognition, and then what can we do to prevent that? So a whole concept that we've been talking about is, just as we talk about cardiovascular health, can we talk about brain health? And brain health encompasses a big, broad spectrum. Obviously, stroke is the best thing we think about, and that has the best linkages to vascular risk factors and stroke. But really, what we're talking about here is dementia, which we often think about as just Alzheimer's disease, but there's also vascular dementia, and then something even bigger than dementia, which is potentially a precursor called vascular cognitive impairment. The American Heart Association has just put out a big scientific statement, huge number of authors that have reviewed all of the literature and talked about some new diagnoses and definitions and approaches to vascular cognitive impairment. So I think the idea is to broaden the concept. When we think about vascular dementia, we often think about severe dementia with vascular disease, including stroke. Vascular cognitive impairment may be smaller changes in cognition on the road to larger dementia in the future. So what we are discussing is the wealth of data now that associates well-known cardiovascular risk factors like hypertension, diabetes, hypercholesterolemia, lifestyle factors that we all know are also affected and related to these cardiovascular risks, and even new concepts like metabolic syndrome, how they relate to impairments in cognitive function. And cognitive function can be measured in a variety of ways. It often requires neuropsychological testing, and we often think it's related to just memory, but there are other concepts, including what's called executive function. Finding your keys, finding your way around, multitasking. These sort of cognitive domains can also be affected by vascular risk. So the concept is, can we do something about it? Of course, when you can modify risk factors, then we can hopefully alter the course and risk of vascular cognitive impairment. The mechanisms by which the brain can get impaired, cause vascular cognitive impairment, involves a number of mechanisms. One, small vessel disease. These risk factors will lead to small narrowings, what we call lipohyalinosis in tiny arteries, and then reduce blood flow to critical areas of the brain. Two, you could cause stroke, small strokes or large strokes, and a small stroke in a strategic area of the brain can impair cognition. Three, large vessel disease, and we think of large vessel disease in the neck like carotid stenosis, where there's reduction in flow to distal parts of the brain that then impair cognition, but you also can have intracranial stenosis, large vessel stenosis inside the brain that impairs blood flow to areas and leads to cognition. Four, cardiac failure, and there's a great amount of literature on how reductions in systemic perfusion to the brain can then lead to changes in cognition. The other big area that is of interest now is what's called subclinical vascular brain disease, and that is what's called white matter hyperintensities. On an MRI, if you do an MRI on 100 people over the age of 60, you're going to find in a good percentage of them that they have evidence of subclinical vascular disease. These tiny white matter hyperintensities, which are particularly related to vascular risk factors and have been shown to be related to cognitive decline. So I think it's an important time, an exciting time for research, and hopefully a time where we will be able to maybe alter the course of vascular cognitive impairment through cardiovascular risk factor control. The other thing that's important to recognize is that even Alzheimer's disease, which we think of as a neurodegenerative disease, has been associated with vascular risk factors. So there are these many new hypotheses about vascular mechanisms through neurodegenerative, through the common cerebral ischemic, through cardiac, and through other, even inflammatory pathways that may be related to increasing the prevalence of vascular cognitive impairment. So as neurologists working with cardiologists, we're hopeful that we can improve the brain health of our patients in the future.
As a practicing cardiologist, I think we all begin to experience patients with this kind of problem. And I have two questions. One is diagnosis, and the second is what are the approaches to therapy? But let's talk about diagnosis. So I have a husband and wife that come in, and the wife says he's starting to forget what he's doing sometimes. So somebody will say, well, there's a natural process that goes on with aging. So what do you do in neurology to decide whether somebody is moving along a natural aging process versus some accelerated process of vascular dementia?
Right. Differentiating what we call age-related memory loss from pathological versus what may be just common with age. So the first step often as a neurologist, we may do very simple tests like a modified mini mental exam. These are very simple screens that are done, even cardiologists can do them in the office. However, to really figure out about cognitive impairment, if you suspect that it's not just somebody forgetting their keys once in a while, but it really is a cognitive impairment, then you need neuropsychological testing. Neuropsychologists are well equipped to then do very standardized tests that then compare to age-matched controls. So you really see, is it just associated with age or is it really something pathological? And they don't just test memory, and that's what's important. Executive function, phonemic effects in language, sequencing tasks, all the different other cognitive domains that are important to really assess vascular cognitive impairment. So neuropsychological testing is the first step when you suspect somebody who may be complaining of some cognitive complaints.
I think that's a good point. I always think of the brain as our central computer, and it's got lots and lots of different functions. So as a clinician, sometimes we get a sense that, well, a little forgetfulness is important. But as you mentioned, there's an awful lot of other functions that you need to do a little more formal testing on. So there are methodologies. I mean, if we send somebody to a neurologist, we're going to get that done. But it sounds to me like with the increasing numbers of these folks, it might be worthwhile for a cardiology practice to have some fundamental testing procedures that can be done. Most of these are fill out a form type things anyway, so they're not too bad to do. Okay, so the next question is, what's the approach to therapy or prevention on vascular dementia at this point?
I mean, the first step is after you would say define through neuropsychological testing if there was significant cognitive impairment, would be differentiating the potential causes. We always think of the worst, Alzheimer's disease, and so obviously brain imaging may be important for that. Is there some other treatable cause? Normal pressure hydrocephalus? Is there a brain tumor, very rare? Are there strokes seen on an MRI? So I think there are still other diagnostic things to do post neuropsychological testing. Let's presume then we come up with a diagnosis of some mild vascular disease and we think it's vascular cognitive impairment. I mean, our first approach is then dealing with the risk factors. Hypertension, is it well controlled? Are they diabetic? Do they have metabolic syndrome? Is their cholesterol in range? Should they be on a statin? All the normal things that cardiologists are thinking about to improve cardiovascular health would be appropriate to try in somebody with vascular cognitive impairment. Antithrombotic agents, should they be on aspirin or not? I mean, if there are signs of a silent infarct, no prior definite clinical brain infarct, there may be indications for being on aspirin. So I think many of the good vascular preventative approaches would apply here. If they have large vessel disease, like carotid stenosis, that may take us down a different path. If they have cardiac failure, that may take us down a different path. So I think you really have to discern what may be the main modality that is worsening the cognitive impairment to then decide on the best therapy.
Okay, so advice from a neurologist is do a good job taking care of your patient's cardiovascular things, and you handled 95% of the issues right off the bat. I think that's important. Lipids, hypertension, diabetes, overweight, metabolic syndrome, all those things we deal with. So if we're doing our job right, we're at least making a big step in the right direction with the patients that have a question about that. So that's important. The other issue that I guess I always ask myself is AFib and microemboli. I mean, where does a monitor come in to look if there's intermittent AFib or something like that?
That's a great point, because I think we probably underdiagnose atrial fibrillation. So say somebody has cognitive impairment, and say you've done the MRI, and there is evidence of some silent infarcts. It may be reasonable, depending on their cardiac history, to potentially do some monitoring. And we know that paroxysmal atrial fibrillation goes up with age, and we know that a routine EKG can miss it. So sometimes prolonged monitoring could be worthwhile in the right patient. And then we know, of course, now with all the great evidence out there, the evidence of the past on oral anticoagulants, including warfarin, but now the evidence on some of these newer agents, the direct thrombin inhibitors and factor Xa inhibitors, that there are great medicines that can reduce the risk of stroke in people with atrial fibrillation. So if you do find paroxysmal AFib or unrecognized atrial fibrillation, that can definitely have an effect on your treatment for ischemic stroke, and then ultimately maybe even vascular cognitive impairment.
That's another helpful tool, again, in the realm of the cardiologist. So the last question I want to ask is that there's all these proposals about brain exercise. I mean, I'm a fitness guy, so I think I can keep my muscles in shape as I get older. What about exercises to improve brain function?
That's an exciting area. So I think the first thing is physical activity, even systemic physical activity, can have positive effects on the brain. And we know that through, obviously, the effects on cardiovascular health, but physical activity itself may be good for the brain. And there may be pathways we're not even sure about of how, for neuronal injury, for neuronal repair, for neuronal plasticity, for other effects in the brain that are beneficial. Brain exercise is still being looked at. It's talked about a lot. It's talked about most in Alzheimer's disease, but it is clear that those that remain cognitively active, doing crossword puzzles or other kinds of tests that will keep them active, even social interactions, can actually delay cognitive impairment. And I think that's a fascinating area, and I think we still don't know the ways that some of these, both systemic physical activity and brain physical activity, could actually reduce cognitive impairment, but it is an exciting area of research.
Right, and I think from my standpoint, again, as a clinician, I end up finding myself becoming a social scientist every once in a while to make sure people are in a social community, and I think you're right, that's an important part of keeping your brain working. Well, Ralph, this is a great review. I think very important area in the world of cardiology, as I said, in particular with the aging population we're seeing. So let me thank you for being here at ACCEL. I think it's a great topic, and we'll try to catch you 2 years from now to find out if we made any further advances in this area.
Great, thanks.